for this presentation, we're going to be talking about the changing demographics a little bit more in the United States, as well as cultural and linguistic competency. So to do this, I'm going to go through some PowerPoint slides. There's also a handout on Moodle. I will tell you a few times to stop, so you can push pause on the video and answer the responses or do the activities that are asked. And then there is also one that you will do at the end of the presentation. So to best do this, I am going to get over to the slides here first, but then I'm going to get out of it so not to have you concentrating on me. So you'll still hear me talking, but you just won't see me. So here we go. So again, changing demographics in the United States and linguistic and cultural competency. So we've talked about diversity a lot this semester, particularly racial and ethnicities and the changing trends, particularly the emerging majority. So now in this section, I want to talk more about the foreign-born population, immigrants, and refugees. So that really diversifies our country. So a foreign-born population, by definition, is anyone that is not a U.S. citizen at birth. And this has really increased in size and percent since 1970. But as you know, we also are founded on our country based on particularly foreign-born population. So I'll show you some trends with that as well. But the majority of foreign-born persons in the United States come from Latin America and Asia, and about 1 in 4 children under 18 in families have at least one foreign-born parent. So when we talk about foreign-born, there's a few different definitions. So they can be lawful permanent residents, and those are defined as immigrants. Refugees and asylees are those that come as humanitarian migrants, and I'll go over those a little bit more. Temporary migrants would include foreign students or foreigners here on business, and then we have the unauthorized migrants as well. So on the right, you see how we've really gone up in the millions. So this is another graph here to show you the percentage of the U.S. population that are immigrants. So the number of immigrants is this blue line here. So you can see how much we've really gone up. This is from 1980 to, we're going up to 2020. But then the percent of the actual population is still it's still growing, but not quite as significantly. And then you can also see how where they are in terms of the United States. So most of the foreign-born population are located in the West and Northeast. Those have higher than the average across the United States, a few less in the South, and then the least in the Midwest. So the number of immigrants in the U.S. and share of the population. So this is just another way of looking at it. And this one also has projections all the way up to 2060. I'll move that up. So just another way to see how, we started as a country. If you go back to the 1900 era here, we had a lot of people coming in, dropped down, and then we've seen that continue to rise over time. The share of immigrants and their children are also on the rise, so that the level of children are growing, and they're expected to grow, but also stay about the same percent of the United States population. Flows by country, so this just gives you an idea of where they're coming from, where immigrant population is coming from. So they change over time. So if we go back even to the earlier 1800s, you see Ireland and Germany and UK and these blues and purple here, and then Italy, Russia, and Hungary they're coming from, and then Canada, Mexico, and Cuba, and Philippines, and China. So really interesting to see how they come from, the flow is from different countries with this one. And then what do they do when they get here? The most common jobs held by immigrants, this is just kind of a look by state. So if we check out Virginia, we've got a lot in cashiers. But a lot of these positions, in the north, west, or east, west here, excuse me, we've got a lot of in the agricultural field and agricultural workers, truckers, housekeepers, janitors, cooks. So lots of different types of jobs, but more so in the lower control, higher demand, and lower paying or lower salary type positions. So when we talk about refugees, so refugees are people that have been forced to flee their home or to escape persecution, war, or violence. So there is a well-founded fear of them actually being in their country. Most of the time it's based on their race, religion, nationality, or if they're a member of a particular social group or have a particular political opinion. So they have this fear of persecution if they return to their country. So they then apply to become a refugee in another country. When a person is applying to become a refugee, they are asylum seeking. They're seeking asylum. So you'll see asylees or asylum seeking. Those are people that they fear persecution, but they have not been awarded by a certain country or government that refugee status. And that refugee status is really important because they then are accorded certain rights by international law. They are able to get services, housing, and access to resources and services where asylum seeking aren't until they get that refugee status. So it's really, really important. The numbers of refugees that we've taken in have reduced under Donald Trump. And so, but there is a huge influx of refugees, particularly in Europe. You know, the whole Syria and war and conflict over there has brought a lot of Syrians. There's a lot from Northern Africa. And so Europe has a very high number of refugees and asylum seekers. So people that are going there to seek refuge. So where are the refugees coming from? So on the left here is in 2018, a lot coming from the the Republic of Congo. And this was actually, I was just updating this and had 2016 earlier, and it was pretty similar in where the countries were coming from. So we're still getting a lot of the same countries, and that also has a little bit to do with the country and who they're allowing in and as refugees there. So I'm from Iowa, as you remember, and I can't remember when it happened, but I think I was in high school and we got 3,000 from Bosnia, and they were fleeing at that time, and in the town right next to me. So that's not on here, but the different times there's an influx from different areas as well. So about 4 in 10 refugees entering the U.S. each year also are children or adolescents. So we're getting, that's on the right side there. So mostly in that 20 or younger age that we see, particularly see in 2016, really high up with some younger kids. They may have lost their parents in war as well and looking for a place. We've had several from Rwanda. When I taught at University of Northern Iowa, I taught a refugee from Rwanda. That was an interesting and good experience. So what does this mean, and why do we care about all of this diversity in the country? Well, I mean, we've talked about it earlier in the semester, in what language and health literacy means, but this is where it becomes particularly important because the immigrants, the foreign-born nationals and people in the United States really need healthcare professionals to be able to communicate with them and address their concerns and do so in a culturally appropriate way. So in 2017, when we look at language, 22%, that's almost 1 in 4, reported speaking a language other than English at home, and almost half, or 48%, of the immigrants ages 5 or older were reported having LEP, or limited English proficiency. So this means that they are even more likely not to be able to understand patient or doctor's orders, or even how to prevent disease, manage disease. So in the current situation with and the coronavirus, there could be a lot of people out there that are not getting the same news and information because they just don't understand it. So language barriers can also negatively affect a person's perceptions of care. It can leave them, may result in them leaving against medical advice. They may not understand, so they may have been asked to stay, or in this case, quarantine. And they may not understand what that means, and they may have very large families at home, and so it's something that we have to be very cautious of. It can result in unsafe situation caused by this lack of understanding of their condition, treatment plan, or even discharge instructions. So I like the little cartoon here on the right, and it's simple. You have hyperglycemic-hemofibrogenesis. I know I didn't say that right, but he, this patient very much likely doesn't understand, and that happens a lot. And we talked about this earlier in the semester, but just want to re-point it out because of these populations in particular. So we got to get more people that are going to care about linguistic competence and health professionals. And this is really the ability to communicate effectively and accurately with individuals whose primary language is not English. So you really need to have professional interpreters. It is a skill, and working with interpreters is a skill. You can't just use anyone. And oftentimes you'll see people maybe use family members or children, and that's not what should be done. You really need to have professional interpreters. So what happens too, there's this term called cultural filtration. And that's when cultural beliefs or ideas are either included or removed from the interpretation process by the interpreter. And so when a person is not skilled at interpreting, they may unintentionally or possibly intentionally, especially if it's a family member, remove particular beliefs or information that would be really important in caring for that person or advising them. So now I'm going to take a few minutes to watch this short video here and change it up. And this is on using language access services, which most hospitals and organizations have, which is really great. But we'll watch this here.
Sarah, hi. Let me check. Megan, Kim, and her mother are coming at 4.
I need to.
Apparently, while Megan is bilingual, her mother, Mrs. Kim, has very limited English. The nurse noted that they had to use an interpreter for her because they had trouble communicating.
Sorry, guys.
And now Megan is going to find out that she needs to have surgery. That's quite a lot to handle for a 12-year-old.
There has to be a better way to communicate with patients who have trouble understanding and speaking English.
Dr. Coleman, Sarah, I'm sorry to interrupt, but I overheard the last part of your conversation about limited English proficient or LEP patients. People bring in family members and friends, or even bring in children to interpret for them. But those unofficial interpreters usually don't have the knowledge or training to convey medical information between a doctor and their patients. This can lead to incorrect treatment and can even be harmful to the patient in emergency situations. One thing we might want to consider for this office is using language access services, or LAS.
Yes, I've heard of LAS. An office hires an outside trained medical interpreter to assist with communication between the provider and the patient, right?
That's right. And you may or may not know that LAS is required by law. Any organization that receives federal funds, like ours, must provide language access services. Of course, it does take an initial financial investment, but studies have shown that using LAS reduces costs in the long term by reducing the length of patient visits so that we can see more patients each day and allowing more resources to be managed. In long term, we can offer our printed materials in English and Spanish, like our surgical instructions and post-op care information. Dr. Coleman, you and your fellow surgeons can use online medical translation service when you are writing a prescription for diagnosis. It is also crucial that we provide all of the informed consent forms in the most common languages seen in this office. Let me also get the number for interpreter services. Give them a call before the Kims come in and see if you can get a Korean interpreter present for your appointment today.
Thanks, I'll be sure to do that.
Okay, so that just shows you an example of using the language access services, which, as they mentioned, is required, especially if you're funded federally. So a lot of the federally funded and federally qualified health centers, like Johnson Health Center in the community, that receive a lot of federal aid for people working with people with Medicaid and Medicare. That's where they particularly have to make sure that they're following and using these access services. So now we're going to move over to culture a little bit more and move into cultural competency. So definition, cultural is integrated pattern of learned beliefs and behaviors that are shared among groups. So culture is one of many factors that influence health status of a patient. So we've talked about a lot of different factors over the semester, those social determinants of health, and those influence a person's culture. But these, when we look at culture, also includes thoughts, styles of communicating, ways of interacting, views on roles and relationships, values, practices, and customs. So these can all really affect how a person is going to choose to access care, if they're going to choose to even go to a healthcare provider, what type of provider they're going to go to, how they view health in general, or how they view disease. So these are really important for providers, healthcare professionals, you as future health promotion specialists, or whatever profession you end up, but being able to understand different nuances that each culture has. So again, it is influenced by other social determinants of health, physical, mental ability, sexual orientation, occupation. These are also linked to one's culture. So earlier in the semester, when we had Dr. Canada in, he talked about the iceberg's concept of diversity. Well, there's also an iceberg concept of culture. So there's a lot that we see above the surface. So an iceberg is, 90% of it is underneath that water line that you see. And so above that surface, you can see, food, dress, drama, crafts, a lot of the things that you associate with a culture. But there's a lot below that waterline that we don't see, or beneath that surface. So some are a little bit more shallow, and you may they cross over a little bit sometimes. And then others are very deep and unconscious. And until you really start working with people and asking them and understanding them, will you really understand. So some of those deep ones, like tolerance of physical pain, for example, is very deep, more deeply rooted. And we're going to watch a short video here shortly related to that one as well. But some of the shallow ones are maybe how much space or personal space someone needs between them, or rules of contact, facial expressions, nonverbal communication, eye contact. So I spent some time in Asia, or in China particularly, and went to some different events, some different feasts with Muslim populations. And they were from all over different Muslim countries and had varying levels of religion on terms of, and particularly patterns of eye contact and be able to communicate, particularly between male and female. So I had to learn to navigate. So first off, the males and the females were separated. The females, we went in and cooked and prepared everything, and the males kind of hung out and chatted and talked, but for me, I kind of mingled around, and some of the males could talk to me. We had great conversations. Some would have contact with me, eye contact, others not, and others completely very distant, and there was no interaction. So it was very interesting to see these different levels. Some would even pray, some did not pray. So it was interesting to see that. So we don't want to make assumptions about cultures either. So there's a lot of differences within each culture that we need to be aware of. So there's resources I'll share at the end. There's books that health professionals use or for cultural competency training to learn about these different nuances and different ways that are typical of cultures to have different rules of contact, for example, what they make, their concepts of food or theories of disease. There may be some overarching type themes that we can learn, but again, we always still want to remember that there's diversity within that as well. So this next part is getting to know your cultural self. So before we roll into the whole cultural competency definition and how to become a culturally competent health professional, you need to get to know your own cultural self. It is the very first step to cultural competency. If you don't understand or know your own, then you can't understand those of others. So this is where I'm asking you to pause for the first time and just hit pause on this video, and you will use the accompanying worksheet to fill out these 10 items here to get to know your cultural self. This goes a little bit along with your heritage assessment that's also coming up, that's due. That one you want to work with your family on as well. So I'll move on here, but make sure you pause and take care of this. So now that you've gotten to know a little bit about your own culture and different things about maybe how you view disease, and the questions that were asked were more so related to diet, nutrition, but you could ask about all different types of behaviors and different things as well. Cultural competency really involves the awareness of cultural difference and then the integration of this awareness into practical skills. So, which will then enhance one's ability to adequately serve a diverse population. Cultural competence is not only a value, it needs to be nurtured as a skill. So I will probably repeat it a couple of times, but it is a lifelong learning and it's developed over time, and it is, again, it's nurtured as a skill, and it's something that you work on and it's always ongoing. Some major components of it are awareness of your own cultural values and beliefs. So that was the purpose of that previous activity, was to first become aware of your own. Then, once you become aware of your own, you can be more aware of other people's cultural values and beliefs and the different layers that make that up. Also knowing and being aware of historical events related to cultures is important, and the diversity within and between cultures that I just mentioned a little bit earlier. Learning about these different cultures and then recognizing that there's subtle differences between cultures or these cultural nuances. And so one culture may, allow you to touch them and others may not. So when I worked with Roma in Romania, one of their nuances was if they were working and going into hospital settings, you could not touch their upper half for women, the upper half of their body with the same gloves as the lower half. So if you were doing any sort of examination, you would need to change your gloves from looking and doing any sort of examination on the top half of the body versus the bottom half. So knowing those things, if you don't, you can really do some damage, and that person, patient, client may never return. And that's certainly not what we want. So there's ways to kind of see where you're at. There's a continuum, a cultural competence continuum. And I'm going to go over this a little bit more in the next slide, but I'm going to ask you to think about the stage that you're in general. So red, and I'm just going to actually move into the next slide. I think it's defines it a little bit more or a little bit better, but and I may come back to this when you do your activity, but so it goes from attitudes that are actually destructive to a cultural group to ones to that purple where you hold that culture in high esteem. So we want to have you move up the continuum, identify which stage you're in. So we'll talk about, I'll come back to this because this is going to be another spot that you're going to stop the presentation for and fill out that worksheet. So the red is cultural destructiveness, and so that's where you're kind of forced assimilation, privileges are really for that dominant group only, that idea of other. Cultural incapacity, racism is going on, stereotypes, unfair hiring practices, for example. Cultural blindnesses is when the differences are ignored. You may think you treat everyone the same, but really the needs of the dominant groups are those that are being met. As you move up towards cultural competency, there's a pre-cultural competence stage, or the green, and a person or you are start exploring the issues. You're committed to assessing needs as a professional, but you not necessarily know, but you're exploring, you're learning. And then as you get to the competent level, or cultural competence, you recognize that these differences, you seek advice from others, you make sure that you're hiring other unbiased staff. And then as you're actually proficient, you're implementing those services based upon the cultural needs. So kind of going back here, this is a little bit more of your own self-check with that. So there are some questions on your worksheet that I want to ask of you. I want you to think about. So again, red, or that destructiveness, are going to be destructive to that cultural group. Moving next, there's a lack of skill and knowledge to effectively respond to their needs. Okay, so maybe you don't have the skill and knowledge yet. You can admit to that when I start asking a few of these questions. Yellow, beliefs and practice that support viewing and treating all people the same. We might find ourselves here a lot. We treat everybody the same. I saw this a lot in previous of your reflections from the implicit association testing, that I treat everybody the same, and we that's great, but sometimes people need to be treated differently. So that's where green, there's a level of awareness about your strengths and areas for growth to respond effectively to culturally and linguistically diverse population. Blue, there's a real acceptance and respect, and then that high esteem is purple. So take a moment here and think about where you are along the continuum, and consider how you believe you respond when you encounter differences at your level of cultural competency readiness. And think of this first, so that first question, just in general. So in general, in cultural competency and dealing and working with people that are linguistically and culturally different than you, where do you think you fall? Okay. Next, where do you fall on this continuum relative to specific minority groups or individuals? So Muslims, where do you fall on that continuum relative to Muslims? Muslim women or Muslim men? Maybe it's different between women and men. What about members of your own culture? What about the LGBTQ plus community? So these are just a few that I'd like you to think about in particular, but any type of cultural, Native Americans, for example, where would you fall in terms of Native Americans and your linguistic and cultural competency in working with them? And then what changes can you make to move yourself up on the continuum? So I don't imagine, cultural competency is quite debated in some fields, because if people think they're competent, then they're competent and they know everything. But that's not the case with cultural competency. It's something that is so ongoing, and you'll make mistakes. So we need to be first honest with ourselves and where we're at and how we can move up the continuum, and particularly looking how we fall with different groups of people. So even maybe think about your own, the population you're working with and doing for your advocacy project. Where do you fall there, and how can you move yourself up the continuum? So again, pause here if you haven't done so already, and answer these questions. The next activity we're going to do is a few video case studies. And so I'm going to show these videos, and then after, please pause and respond to the corresponding questions on your worksheet. So this first one is on cultural and religious beliefs. And we will see an interaction between a doctor and a Muslim woman here.
Hello, Nadir. I'm Dr. Calais. I'm filling in for Dr. Smith. Looks like you had a very successful surgery last month. How's your recovery been?
Well, thank you.
I'd like to begin by doing a quick examination of the location of your surgical wound, just to make sure you're healing correctly and everything looks healthy. May I ask you to remove your head covering?
No, I cannot remove my hijab.
Nadira, I want to make sure that you're healing from your surgery correctly, and in order to do that, I need to take a look. Did Dr. Smith not tell you this would be part of the follow-up?
Well, Dr. Smith is a woman, and you are a man. And I cannot remove my hijab in the presence of a man who is not my husband. But that is why I came here, to see Dr. Smith. She can be the only one to do my examination. If Dr. Smith cannot be here today, I will have to reschedule my appointment.
All right. Why don't you wait here a moment, and I will check and see if she's on her way. Elizabeth, I'm glad you're here. This patient of yours is giving me a heck of a lot of trouble. I'm trying to examine the sutures from her surgery, and she won't remove her hijab. How am I supposed to do a post-op checkup with her?
Nadira Ansari. Well, I understand, Michael. It's part of her cultural and religious beliefs that a woman may only remove her hijab in front of her husband. But even if we don't fully understand it, we need to respect those beliefs when treating patients. Well, I better go check on Ms. Ansari. What room is she in?
3B?
Thanks. If you want to catch up later and talk more about this, we can do so.
That'd be great. I'll catch you at lunch. Bye.
Okay, that was the first one that we're going to watch. The second one is on culturally tailored healthcare in orthopedics. This is with a young gentleman regarding pain. So with both of these, you want to take a note of kind of the interactions that are happening between the doctor and the patient, and based on these, and thinking about the nuance, their cultural nuances, and how they're affecting their interactions, as well as assumptions.
Nice to see you again, Carlos. What brings you back in to see me? The prescription you gave me after the surgery ran out. My knee is still killing me. Every time I put pressure on it or go to physical therapy, the pain is terrible. I could really use another prescription of those pills. I gotta get back to work full time, stop paying off these surgery bills.
Carlos, I'm not going to write you a prescription for a stronger pain medication. Prescription pain medication can be addictive and should only be taken when necessary. And over-the-counter drugs should be sufficient to take the edge off the pain you're having now.
Okay, I've been taking those already, but I don't think it's gonna be enough.
The discomfort you're experiencing is not out of the ordinary. And as we discussed before surgery, I anticipate you should continue to get better over the next several weeks. Now, is this the only issue we need to discuss today, or is there something else you want to talk about?
I guess that's all.
All right, we're going to come back in. I'm going to take a look at that knee in another month or two, right?
Right.
Hi, Elizabeth. How are you?
Cliff, hi. I'm good. How are things?
Things are good. That hip replacement yesterday went quite well. But I can't seem to get this patient I saw this afternoon out of my mind. A month or two ago, I performed knee surgery on this Rodriguez patient. The thing is, he just doesn't seem like the type that would be looking for a quick fix. I thought maybe it was just because he was so desperate to get back to work.
You said his surname was Rodriguez. I'm guessing he's Latino.
Yes, his.
I read a study recently that you should take a look at. The results were quite interesting. The study indicated that post-op, Latino patients reported more pain in each follow-up than Caucasians or African Americans across the board. And even though this study refers to radius surgery, these data may be indicative of a more generic finding related to your patient's ethnicity. Since your patient is Latino, he may legitimately feel more pain and recovery than the patients you usually see.
I'd like to read the study you're referring to and get more information on the topic.
I'll look it up and email you about it later today. In regards to your patient, you should take care to listen to him and consider his pain assessment in detail before dismissing his complaints as drug seeking.
Yeah, you may have a point. I'm going to have Sarah give him a call and make another appointment. Get some more details. Thanks, Liz.
Okay, so take a moment here to pause the presentation and answer the questions on the linked worksheet. Okay, so Dr. Smith in those videos was really good at showing how to provide culturally appropriate care and educating her fellow providers. So what we mean by culturally appropriate care by definition is when a professional, provider, or organization is sensitive to the cultural differences among their clients, actually understands the influence of these differences on their health status, and then can modify programs and practices to meet the specific needs of diverse populations. So it was really great that Dr. Smith was available to educate them, but it was after the fact. So better yet would have been able to, these providers to have been able to provide culturally appropriate care and consider the cultural nuances and differences among their clients as to begin with. So what do? We've got this huge growing population. You cannot expect to know how to work with everybody and know how to do it in a culturally appropriate way, right? So there's resources and referrals out there. Do you know where to look for more information first? And so that's a question you'll ask when you start getting in the field and figuring out who it is that the populations that you're working with, but also knowing where to go for more information. This book is awesome. It's a really big go-to book in terms of providing culturally competent healthcare. It's by Larry Purnell. And in the book, it provides tables and information on all different types of populations and their healthcare practices, their beliefs, their death rituals, how they go about communicating, and some of those nuances with communication, how maybe family roles, the dynamics that are involved there that can also really influence care, or how people are gonna take the advice of doctors, for example, or if they have to get permission from someone in their family. So this book is really, really good. I would recommend it if you get into a position that you are working with a variety of cultures, and use it as kind of your resource in the field for that. You can go online, but it's so mixed, and this is really evidence-based by this Larry Purnell. Then you need to know where to make referrals. So if you can't, or if your organization can't provide the care that's needed or the information that's needed, where can you send the population you're working with? Where can you send that person to get the appropriate care and quality care that they need and deserve? So those are things to think about. There's not a one size fits all, but this book is one of the best in the field that I've found. I've used it quite a bit myself. There's also national culturally and linguistically appropriate standards. These are found in the back of your textbook as well, if you want to take a look. I'll pull them up here as well just to see, but the principal standard number 1 is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So this is the base, the principal standard number 1. You can get these online, so when you are in the field, you can access them. If you don't still have your textbook, we'll see if it's gonna pull up here. It did the other day for me, oops. And it's not pulling up, so that's okay. Just make sure to look at the back of your textbook for that. I'm just gonna see if I can get the right oops, sorry. So it's Appendix 1 on page 215 in your textbook, and you can look through the full standards on this. But it's if you would take this to your employer, you're in an internship and they're working with different cultures and they don't know, or they're not doing things appropriately, this is what you can go to. These are the standards set. So definitely think about that as a resource going forward. So I want to take a minute here to share you a traditional Tanzanian folk tale. It's a cultural competency tale. And so it's called How the Monkeys Saved the Fish. The rainy season that year had the strongest ever, and the river had broken its banks. There were floods everywhere, and the animals were all running up into the hills. The floods came so fast that many drowned except the lucky monkeys, who used their proverbial agility to climb up into the treetops. They looked down on the surface of the water where the fish were swimming and gracefully jumping out of the water as if they were the only ones enjoying the devastating flood. One of the monkeys saw the fish and shouted to his companion, "Look down, my friend. Look at those poor creatures. They are going to drown. Do you see how they struggle in the water?" "Yes," said the other monkey. "What a pity. Probably they were late in escaping to the hills because they seem to have no legs. How can we save them? I think we must do something. Let's go close to the edge of the flood where the water is not deep enough to cover us and we can help get them out." So the monkeys did just that. They started catching the fish, but not without difficulty. But one by one, they brought them out of the water and put them carefully on the dry land. After a short time, there was a pile of fish lying on the grass motionless. One of the monkeys said, "Do you see? They were tired, but now they are just sleeping and resting. Had it not been for us, my friend, all these poor people without legs would have drowned." The other monkey said, "They were trying to escape from us because they could not understand our good intentions. But when they wake up, they will be very grateful because we have brought them salvation." So I like to share this folktale because it's often what health professionals do. It's what we do in our daily interactions with people that are different than us, that are from other cultures. But we want the best for everybody, and we think we know what is best. The monkeys thought they knew what was best for the fish and thought that they could help them and pull them out of the water to safety. But that's not what the fish wanted. That was not part of the the culture of the fish, who need the water to survive, just like other cultures have certain beliefs and things that we need to consider. So if we don't truly understand and know the cultures and the way of life for the people that we are working with, we can ultimately do damage. They may not want to come back to get care again in the healthcare setting, but in this folktale, unfortunately, they die, but which can actually happen in healthcare if there is that bad interaction and they don't go back, or a doctor or a professional thinks they knows what's best for the client or patient, and it turns out that it is not. So we need to work on being more culturally competent in the health profession, and you as future health education specialists or health promotion specialists or whatever profession you're in, really being able to be culturally competent is important. So how do you do that? Well, you need to become familiar with your client's traditional health practices, their attitudes and their perceptions about different conditions. Again, those different historical events, understand how oppression or discrimination and stereotyping affect your clients, and also determine the communication styles most common to your client's culture. So that book by Larry Purnell that I mentioned was really, really good and can be a good tool for learning more. Also being aware of cultural taboos. So what I mean here is there's some things that could be real no-nos when you're working with a culture. Like I mentioned with the Roma and, needing to use gloves, different sets of gloves from the top half of the patient to the lower part of the patient. So something in a personal story that I spent many summers, 5 or 6 summers in China. My master's thesis was all about Chinese children and delivering English language immersion programs to Chinese children. And I thought I was pretty darn competent in the Chinese culture. And where I went to school at the University of Northern Iowa, it was when I was getting my doctorate. So this is after years I'd been spending in China, and I had many friends from different Asian countries, and particularly China and Taiwan. And this friend of mine got married, and he was Taiwanese. And this is of course when I was in college. I didn't have a lot of money, so I went shopping in my mom's closet. She had always had different things in case I needed a present for somebody. And she had these really wonderful kitchen shears. And so I got kitchen shears and I put them together with some nice kitchen towels and did a nice little set. I wasn't able to go to the wedding, so I gave the present. And a couple weeks later, he comes into my office and he sits down and he says, Jenny, why did you give me those kitchen shears? I'm like, they were really wonderful kitchen shears. You can use them for everything, and they're really great for cutting meat. And I knew he loved to cook, so I thought it was great and perfect. And he goes, do you know what they mean? And I said, no. And he said, when you give shears or something sharp, knife, scissors, it is bad luck, and it means that a relationship or whatnot can break. It can be ruined, and it is not good luck. And that was a major taboo, and I felt terrible. I apologized. I said, can I have these kitchen shears back? I will get you something else. And he said, no, it's fine. One, I was so grateful that he came and educated me on that. I felt terrible. But two, I acknowledged it. I said I was sorry, and I will never do that again. And that's going to happen. The reason I tell you this story is because it's going to happen even in those communication styles. You may stand too close to somebody or have inappropriate eye contact, different little things that can be really offensive to someone you're working with. And you just need to, hopefully they will educate you and tell you. Otherwise, you need to actually, when they do educate, and be humble about it and apologize and learn and not do it again, right? So you want to, moving on, you also want to be aware and sensitive to your own and to your client's cultural values and beliefs, and recognize how they influence your client's attitudes and behaviors. A few more things that would be really great are learning a few introductory phrases in their language, taking time to ask questions and listening actively, learning specific factors, risk factors, signs, symptoms, barriers to prevention and methods of treatment, to managing diseases that are culturally specific to them, and learn more about the cultural communities in your area, or once you are in an organization, the cultural communities that are served by that organization. Use a sense of humor and be humble, genuine, and willing to learn. So I was very humble with that, and it was a very eye-opening experience for me. And I like this little cartoon here on the bottom, snowballs. I thought we were discussing coconuts. So there can be a lot of times we are talking about something with a patient or a client in the future, and it is completely coming across differently to the person that we are working with. So that cultural humility that I was talking about, and being humble, is that willingness to learn. So this quote by Joe Gallagher, to be culturally humble means I am willing to learn. And by a longer definition, it's the ability to maintain an interpersonal stance that is other-oriented or open to the other in relations to aspects of cultural identity that are most important to the person. So a person-centered approach is really key in this. Having an open and honest attitude, honest and sincere intent, a genuine desire to learn and share, and knowing that everyone deserves respect. And again, just like cultural competency, it's going to be a lifelong process. And in cultural humility, it requires self-reflection, it requires self-critique to go with that. One more definition here, we're almost done, is consciousness. And this is something that I've pulled in. I've presented on this topic. I've done trainings and presented it differently. And I added this just about a year ago. And that's that we're conscious, because we can think we're competent. We learn about things. We're humble. We're willing to learn. But when you're interacting with someone, you need to be conscious and culturally conscious of those differences and nuances. So this cultural conscious is that state of being aware, especially of something within oneself as it relates to cultural nuances. So understand that what you're doing, how you're interacting, it could very much be affecting and impacting the person you're with. So it's being conscious of the external person as well. It's being characterized by sensation, emotion, volition, and thought. So there's an actual state of being in the mind. There's that awareness, especially concern for social or political cause. And it's an upper level of mental health of which a person is aware, as contrasted with unconscious processes. So again, as this particularly relates to cultural nuances and those differences, those subtle, they may be very subtle differences between others. So when you're working with people and thinking about consciousness, are you working in a consciously competent way? If you're maybe more like Dr. Smith in the video, some of hers could be unconsciously competent because she's been working with people of different cultures for a long time, and she just has that ability. That's the ultimate, right? Is to get unconsciously competent and just work and provide culturally appropriate care at all times. That's probably not going to happen, especially with every population. And so again, just like that continuum, you may fall on this spectrum here in different places depending on the population you're working with. But being conscious is going to be important. And last slide here, thanks for hanging in here, is cultural competency plan. And that's what organizations need, health service and public health organizations, universities, businesses, you name it, really need to develop and implement robust cultural competency plans. And these plans cannot be a one-size-fits-all approach. They need to be responsive to the diverse populations that are emerging in the United States, that are here in the United States, and particularly the ones that the organization serves. If you don't have this plan, then we can really it can be detrimental to these patients and lives of patients and clients and people. So having a plan is really necessary to address the changing demographics that we've talked about today and earlier in the semester, eliminating health disparities. It's also necessary, we got to improve those health quality of services and health outcomes, comply with legislation and regulations, and decrease potential liability or malpractice claims. So a lot of important reasons why to have a cultural competency plan. This is at the organizational level. So organizationally, strategy or solution is to have a plan, is to implement that plan, evaluate it on an ongoing basis. And then at the individual level, having trainings or opportunities for staff and for professionals to get the training to become more culturally competent. So that is it for this presentation. Thank you very much for hanging in there. It is the first online presentation you've had with the course. So now take the time to finish up any of the questions on that accompanying worksheet that you haven't had a chance to fix yet. And then there are a few questions at the very end that are just one question at the very end to provide briefly 3 things that really stuck out to you in this presentation that you learned, maybe that caught you, that was something new, but briefly describe 3 things that you learned in this presentation. And then submit that to Moodle and you'll be done for this assignment. So thanks again for hanging in there, and we are